Thanks, Peter. Appreciate it. And thank you for inviting me. Speaking of travel, and I have traveled quite a bit in my life, not just from the AUA, but I travel a lot. But this is actually my first time in Canada. I had to really think about it. So thank you so much for inviting me. It's, I've always wanted to visit. In fact, when I told Matt Nielsen, who's our chair at UNC, he was very jealous. He said this is on his bucket list to come to Vancouver. So I was like, I'll put a plug in because maybe you invite him too sometime. But yeah, I just want to say thank you again for the invitation. Warm welcome. I really enjoyed talking with the residents and fellows yesterday because it's, kind of creating a life you want is really critical. It's everything because it reflects on what you do in the clinic and the OR and research and all of that. So having really good, clear goals on that and constantly reassessing them is important. So with that, I'll transition to what I'm talking about today, which is patient engagement. And I entitled this Integrating Patient Engagement to Clinical Practice and Research, because I know and I can understand I probably have here a diverse audience in terms of what you might do. I might do research, you might do translational research, clinical research, you may not do research at all and really be in the clinic. So I tried to make this as broad as possible because I do think patient engagement touches every single aspect of what we do. And so these are my disclosures. All the grant funding I have is actually very much related to patient engagement in one way or another. Patient-reported outcomes, which I'll touch upon today, it's generally what I get funding on. And my consultant work is often trying to incorporate patient-reported outcomes into clinical trials. It is easy to do so, truly, if you think about it ahead of time, and that's always the key. And it's a missed opportunity when we don't, because in the end, the patients are typically choosing the treatment they're going to receive. And in order to accurately choose the right treatment, they really do need to understand the benefits and risks, some of which are patient reported. So as I begin, I typically like to think of a little thought experiment to get us in the right headspace. So while this isn't a perfect analogy, I'm going to ask you to just think, like, if you're developing some kind of product that you're going to bring to market, and you don't think about the consumer needs, you don't involve the consumer in the way that you develop that product, and you don't involve them in marketing it, you tell me that, that product's not going to be likely to be successful. But, if you really think about what we have done traditionally in the clinical realm and the research realm, we don't always bring the patients in when we prioritize the research that we do. We try to think of the patients from our own experience with them, but we don't necessarily bring them into that process. Our clinical discussions often are one-sided. Like, we do a lot of the talking in the clinic, and I will put my hand up, I do the same. When we give treatment recommendations, typically us, again, very one-sided. And hopefully we're moving away from that, but that's often the case. We don't typically bring the patients in for designing the research and conduct. And then, in terms of the way we educate, how often do we bring patients in to find out how well we're doing? And how do we bring the patients in for disseminating and implementing research that are already conducted? So you can see where I'm going with this. And, very, very traditionally, we don't bring the patient in, but it's really a missed opportunity because they can provide some valuable information for us. So what the research we do is patient-centered, because in the end, that is why we conduct the research. In the very end of the day, we want to improve the lives of our patients, right? Whether it's developing a new product, whether it's or a new drug, or whether it's improving side effects or whatnot, it's all in the end for them. But as I mentioned, I don't think this is a perfect metaphor because, patients aren't consumers. So there's a lot of nuance here. So in the next 50 or so minutes, I'll keep an eye on my time. Oh, good. There's a clock right here. Perfect. I wanted to convince you that patient engagement is important, no matter what you do. And so I'll talk a little bit about what patient engagement is. I'm going to try to convince you why it's valuable. And then I'm going to use examples of patient engagement in clinical care and research. And then I'm going to end with some strategies that I've found that have been helpful for intentional engagement, because I do think you have to think about it, just like many things in our life. And continuing the theme I talked with the residents about yesterday is just being intentional, being thoughtful, because we do go through life. Life goes fast. We don't always pay attention to what's around us. So I'm going to start with clinical care, and then I'll go to research, and I'll kind of bounce back and forth a little bit, and then I'm going to share an example of my own path into this space, because I didn't know very much about it, I'll be honest with you, and then I started about 10 years ago looking into this, and I've built a research career around it. So first of all, patient engagement value in the clinical care delivery. This has actually been well known, and there's been a lot of health policy briefs. This is one that I just highlighted. The way that most folks define patient engagement in the clinical sense is what they call patient activation, which is basically patients who are activated to participate in their own healthcare, whether it's making those decisions in their treatments, obtaining preventative care. For us, like I'm Uro-onc, so active surveillance, them coming back for their PSAs or their follow-ups and things of that nature. But that is believed to be very important, and there's an entire continuum of engagement in the clinical sense. So you can see, I like this chart because it shows you different levels of engagement in two different dimensions. The first is on I guess what would be the y-axis. You see like direct care and organizational design all the way to policy making, which is important. And then you can see on the other side, how do you activate the patient within it? Is it consultations? Do you ask a patient? Do you involve them actually within that process? So if it's direct care, you're asking them about their treatment plan, thinking through like shared decision making. If it's policy making, or is there a patient that's actually on the committee that makes those policy decisions? I would argue that probably should be happening. They have a viewpoint that is different than ours, no matter how well we think that we are advocating for them. We're not necessarily walking in their exact shoes. So thinking through that kind of continuum. And there's value, lots of research. So I told you I'm trying to convince you. So anytime you convince someone, you're going to put in a little bit of research here. But there's a lot of evidence that shows that patient activation engagement in the clinical sense is better for everyone and better health outcomes. So this is from a large systematic review that puts together many different studies. But they show that patients who score higher on a patient activation measure, which is a measure of engagement in the clinical sense, are significantly more likely to engage in the preventative behaviors. You can see here that less activated patients, less engaged patients are 3 times as likely to have unmet medical needs. They're twice as likely to delay medical care compared with more activated patients. So getting them involved in their care and understanding it is really important because it leads to better health outcomes. And then better health experiences. So I don't know, in Canada, do you have like patient reviews? Yeah, I mean, we may not sometimes like what is written. Sometimes we do. And we may not think it's fair to have them, but they exist, whether we like it or not, and we're judged upon it. So in the US, I get every month a list of all of my patient reviews and comments, and whether I like it or not, I'm judged upon that at my institution, and many institutions do that. And other patients, they look at it. So we should care about their health experience because that's usually reflective. It is, but I'll tell you, most institutions in the US, they do it. And even if they don't, there's vitals.com, there's healthgrades.com. If they don't do it, someone else will. And they're putting your name in Google, they're searching you. I had to get a new picture because my lighting showed me with blonde hair, and I was so sick of people like, I searched you and you have blonde hair. Like I don't have blonde hair. But anyway, but I know like people are searching you before they're looking at you. They want to hear like what you have to say, and they want to see what other people have to say, other patients have to say about you. So we should care, but there is evidence that if a patient's more engaged, they're likely to appreciate the experience with you in a better way. So again, I'm trying to convince you, but it does help. And there's also evidence of lower healthcare costs. So patients, and this kind of makes sense with the health outcomes, right? These patients who are more activated, more engaged, they're less likely to need the ER. They're less likely to seek other care, hospitalizations, et cetera. So patient engagement is clearly valuable in the clinic. It's invaluable in research too, but it's a little different. So I shift a little bit because it's a different definition. So engagement in research is, So it depends on who is the audience here, but I'm going to talk today about patients, but it's really all stakeholders. So the true definitions is the meaningful involvement of patients and caregivers and clinicians, healthcare stakeholders, really everyone throughout the entire research process, from planning the study, and that means identifying the research question itself, to conducting that study, to disseminating the study results. And this was introduced in the UK in the early 1990s. So it's not absolutely new, but I do think it's coming to the fore now, much more than it ever was, in part because Involve in the UK kind of elevated that. And then PCORI, the Patient-Centered Outcomes Research Institute, we talked a little bit about that at dinner last night. They are a funding organization in the US that focuses on the patient's voice and understanding some of the questions that are not always asked. So patients have choices between 2 treatments, 3 treatments, sometimes more. What are the aspects of that treatment that lead them to the right treatment choice for them, right? So it could be many different elements, not just efficacy, because we seem to always believe that that's true. And of course, it's important. It's not everything, especially for patients. And there's value in the way that we engage patients in the research process. This is, again, I'm using a systematic review, so I don't have to do 15 slides of convincing you of all the evidence. But in this systematic review, looking at numerous studies showing that if you involve the patient in the process of your research, especially clinical research, you improve recruitment, you improve retention, you destigmatize some disease stereotypes, you get better training materials. I think of so many examples. In fact, I'm on a study, Max Cates, we were talking about Max Cates yesterday, who is at Hopkins doing bladder cancer research, putting together a study that is going to hopefully compare BCG and gemcitabine docetaxel de novo, like in new non-muscle invasive bladder cancer patients. And we have patient advocates on that study. And I just got some emails last night, right before I went to bed. I looked, it was my 2 times a day. They know I have 2 times a day, I check email. And I got, Mark, I finally got your email that you were coming to visit me. So he sent me a little note. But in any case, in that email, 2 of the patient advocates had written back, and they had looked over the consent. And they said, I mean, the things they say that I was like, that makes a lot of sense. Oh my gosh. They're like, if I was enrolling in a study, I would not. And here's why. You don't talk about any of this. And this is what I would be concerned about. How much value is that? Now, it's no wonder the way that we've done this, especially for clinical trials, when we don't involve the patient, half of our clinical trials failed because of lack of recruitment. Well, it stands to reason if you add the patient into the mix, understanding some of those barriers and addressing them up front can really make a big difference in the way that you do it. So I'll show you some examples of my own, but trust me on the fact that there is value here. And it doesn't take a lot of effort. It just takes some intentional, effort to add a few patient advocates, pay them. We pay them. Even if many of them, they don't want to be paid, you want to provide value. They're part of your research team. And that's it. You keep them involved in the process. And just like there was that continuum for patient engagement in the clinical realm, there's a continuum on the research realm. So again, there's sort of on that y-axis the engagement best practices, and you can see a variety of principles of engagement like respect and trust, empowerment. But I think what I would draw your attention to is I don't think I can point to the screen. That's fine. You can see there's different ways. Yeah, that's what I was doing. But you can see it. Oh, there it is. Okay, sorry. It was just, yeah. So you can see like research, training, and education. You can bring them into budgeting. You want to make sure that you're thinking about all these different. So it can be simple. It can be complex. I wouldn't let this deter you into doing it, because you can start very small in this. You don't have to do all of it, but I always say, like, you should have like a goal in mind of what you want it to be. And the good news is a lot of this stuff, and if you are really, you hear this talk and you're like, I really am interested in this, I'll have my email at the end, and I'm happy to provide more resources. But all of this exists. You don't have to create these things. PCORI has them for free. They have like ways that you can create a contract with your patients. All this is for free. So you don't have to reinvent the wheel. It exists. So I told you I wanted to show the value. So that was that. I want to now go into some examples of what I mean by patient engagement. I'll share a few of my own thoughts about examples in clinical care, and then I'll shift into research, and then I'll end with some strategies. So I don't think there's any better example of patient engagement in clinical care than the guidelines that we use. And if you look closely at the guidelines that exist, and if you look at the authors, more and more you end up seeing a patient advocate. Like people know that having patient advocates on the guideline panels make a lot of sense. They actually read them. Not all of them do, but a lot do. And so for the AUA guideline articles, I'm going to show bladder cancer, but I can tell you also I looked at, for FPMRS, they actually have a woman advocate, patient advocate. They have different advocates, and I know they're going to be doing, I think, is it, it's not recurrent UTIs, it's another new one on female sexual dysfunction. That's what it is. And they actually put out a call for patient advocates to join their team. So, and that's important, but this is one way that patients can get involved into crafting guidelines that we use every single day with them. And even if you look at the NCCN, they have actually a guideline for patients, again, with patient advocates on it. So if you look closely, this is happening. And then if you look at different studies, this is from urology practice. This is just one example, but this is a study that looked at wearable technology, but in the patient's view. And we in urology, I just saw on Twitter, I did look at Twitter this morning very quickly, but there was a little, not argument, but a little back and forth about technology and urology. And, we have been innovators from the beginning. And somebody said, we must innovate. And someone's like, we don't have to innovate, but whatever your stance is, whatever you do, if you're going to put something new into our clinical world, don't you want to make sure that the patients use it and the patients want it? And so this is just one example of many. And you can do this. You don't have to be a high impact researcher to do this. There's quality improvement surveys. You just have to have some creativity and some interest in identifying how this is going to help your patients and your patient population and what you can do to actually improve whatever you're using. So if you're doing wearable technology and you want to incorporate this into the clinical space, find out where the gaps are. Why would patients not use it? And then do that before you do the trial. You want to do a little bit of usability, and that's where patient engagement can be really helpful. So I put this in here. This is John Gore. We talked about him. He's just a few hours away at University of Washington, and Matt Mosin at Harvard now. They are doing work on patient-centered pathology reports. And has anyone heard about this? So the idea behind this is, we get our pathology reports, of course, and, they're written in medical language. I would not say they're very translatable. And yet patients, at least in the US, I don't know how it is in Canada, but the CARES Act was just passed, which means, this is very hot off the press, maybe this past year, which means that as soon as the pathologist clicks submit, we see it, we might see it, but, I might be in the OR, so I'm not going to see it for whatever, 6 to 8 hours, right? But the patient sees it immediately. And that's become, I don't think it's necessarily good or bad, but that obviously creates some issues. And let me tell you, some calls, angry patients, that I had to address in my own clinic. And so things like this is understanding what do the patients need in that setting, because that's not going away, at least for us, anytime soon. So we need to adapt and figure that out, get patients involved in the process so that maybe we have a compendium, patient-centered pathology report that can be built and almost auto-populated based upon the words within the report. So this is another great example of patient engagement within the clinical setting. And then I want to spend the rest of the time in the clinical setting talking about patient-reported outcomes. And this might not be new to you, but if it is, a patient-reported outcome is essentially an outcome that is reported directly from the patient. And I'll get in that in a minute. But this is a study, and there are many studies looking at patient-reported outcomes after in this case, radical prostatectomy. And so why do we care about that? Well, first of all, that can be very helpful in their treatment decision making. It's helpful in their patient counseling to understand, what is the right patient for me. It's like the PCORI, Patient Centered Outcomes Research Institute mantra is, the right treatment for the right patient at the right time. It's not the same answer for everybody. That's why understanding this in a broader level can be really helpful when you're trying to come to a shared decision for a treatment. So I'm going to just take a little minute to talk about patient-reported outcomes, and maybe you can reflect. You might use this already in some way in your clinic, and if you don't, could you? And would you? I think that there are lots of patient-reported outcomes out there, no matter what you do. Urologic oncology, yes, there are many there, but there are many for lots of other conditions as well. So questions that I always ask, I always say it at a low bar and then a high bar. So low bar is, does it measure something appropriate for direct patient report? So it's something that actually matters from the patient's perspective, and it has to be something like how they feel, how they function, something that really has to come from them, not from you. And then the higher bar is, there's science behind this. They call it psychometrics. Is it valid? Is it reliable? Are the questions appropriate? Were the items or the instrument developed with patient and clinician input? So these are the types of things that we look at when you're assessing a PRO. It's a little dangerous to just create your own, because you really don't know what you're measuring. You haven't tested it. Your words may be very much misinterpreted by patients, and that's why that whole field of psychometrics exists, because they really painstakingly figure out what the words are. Are they being interpreted in the way that you intend? And so these are just some common patient-reported outcome measures or PROMs. Some of them are symptoms, and maybe you already do that in your clinic somehow. Functional status, quality of life, self-efficacy for managing a condition, but you can kind of sort through your own clinical practice and where it might be helpful. And there's lots of uses that you can think about in healthcare. So I'm going to talk a little bit more about the patient care, like the direct patient care, but then later in research, I'll talk about comparative effectiveness research and how I'm using it there. Healthcare systems use it for quality assessment. In some ways, what I was talking about, that experience, the surveys that they send about me, that I get the report on myself every month, that's actually technically a PREM, patient-reported experience measure, but it's not that different from a PROM. Okay, it's very similar, and so healthcare systems are using that, not just mine, many. And then, and patients will use this for decision making, as I mentioned. So just a really quick blurb about why I think they're so important. There's some good research that what we believe a patient's symptoms are often misaligned with what the patients really think they are. And so you can see, this was a study from the New England Journal where they looked at the agreement of patient clinicians. They did it simultaneously, didn't tell the other what it was. And you can see how yellow is patient reported. So patients often reported much more symptoms than what the provider or the doctor, the APP, the clinician reported. And maybe it's because we don't ask, maybe we don't ask the right way, but the point is we're missing a big piece of the puzzle. I mean, look at how big these gaps are. This is a really large study. Part of, in my opinion, about this is we don't have time. We talked about this yesterday, time management, right? Like, we don't have a lot of time with our patients, unfortunately. There's pressure to see as many as you can. You want to help. And I mean, I think that it comes from a good place. We want to help a lot of patients. But we don't have a lot of time to talk to them. So these are consultation. I like this study, and they recorded, some of them were urologists, specialty care, some primary care, but the median counter was 30 minutes. So I'm going to ask you all, just you can shout out your guesses, how long it took. Like, they watched every single consultation. How long do you think it takes before the clinician interrupts the patient and just starts talking? Any guesses? Or if you guess, I'm not going to assume that's what you do. Okay, I'm going to assume that's what like Peter does. So. Any guesses?
1 minute.
5 minutes? Okay. I love that optimism. Any other guesses? Minute? Okay. Yeah, so the answer is 11 seconds. 11 seconds. Like, if we were doing Price is Right rules, no one wins here, okay? 11 seconds. I mean, that's pretty amazing for a 30-minute encounter. We interrupt that quickly. And so that's why I think PROs have a role. I don't see them as creating time in your clinic. I actually see them as saving time. And I'll show you a little bit of what we've done at our institution with patient input, and it saves me time. We talked about this in my talk yesterday of how I interact with my patients so that I can really have a conversation with them about the treatment, because that's really what you want to get to. But you still have to have the history first, and that can take a long time. So if you can optimize that time, you can shift the focus to the goals of care and what you're going to do about them, which is really where the bulk of the time hopefully should be spent. The important thing about PROs is that if they're used in an effective way, they improve satisfaction. So I share this slide because what this shows, so this is provider communication in green and shared decision making in blue, and this is like what the patient satisfaction in that. So if no PRs are completed, like people are pretty satisfied, like 80%. If the PRs are completed, but they're not actually discussed, it's the same number. But if you have them completed and then you actually bring that into the conversation, it really jumps up. And that actually matters, that difference. I mean, it's like, well, it's 80% good enough. I can tell you, like at our institution, it's not good enough. They want you to have really good patient experience measures. You want the 90+%. And so that's how I use it in my clinic. Is I already know what the PROs are, and they're automated. And right away, before I even walk in that door, I can see what's changed. So we get into it. I'm like, hey, thank you for completing that survey. I noticed that sexual function went down from the last time that we spoke. You want to talk a little bit about that? And then they feel heard, and they're like, not doing. I mean, how many times have we all done a survey and we don't even know if anyone actually read it, or and we have survey fatigue. So you actually do something with it, but you do it in a way that helps everyone, including yourself, get through your visit. One of my really good friends now, he's a mentor of mine too, but this made a big splash at ASCO. It was on the plenary, and he did this study in which he randomized individuals to either having PROs or not. And this is for advanced cancers, including some urologic cancers. And this is the interesting thing. He never told anyone, like, here's what you got to do about them. Here's the thresholds for PROs. He just did them. That's it. And they found that it was a significant difference of survival and significant difference on chemo, being able to remain on chemo longer for those who had the PROs than those who didn't. Why? Probably because we were doing a better job of addressing all the side effects of that treatment. And by doing so, you actually can get the treatment longer. And then you can have the benefits of that treatment without some of the side effects. So it's a big splash, because, I mean, think about how many chemotherapeutic regimens that we spend so much money on with the same effect. And all this was just asking their opinion. Just asking them about the symptoms. That's it, and making it systematic. That's all. So I told you I share a little bit about what we're doing in the clinic. We, I said this yesterday also, like a lot of things coming up again. I said, anyone who's scared to do something, you just say, it's a pilot. It's a pilot. Don't worry, it's a pilot. You can always not do it, but we asked for a pilot to do electronic PROs in our clinic. And so we did one in the primary clinic. I requested that we do one in the GU Oncology clinic, because it makes a lot of sense for like prostate cancer, bladder cancer, a lot of symptoms, especially for prostate cancer afterwards, like for survivorship and treatment decision making, et cetera. And we were already doing that, honestly, in our clinic. We were just doing it on paper. So we did that, and we created a workflow. But if you're thinking about doing this in your clinic, there's a whole quality improvement philosophy on doing this effectively, because I knew that if I wanted to do this in the clinic, I did not want to create extra burden on the clinicians. I was like, no, I mean, I'm one of them. I don't want to do it either. I'm busy. So to automate as much as possible, the process was really key. And we're actually going through one more iteration right now of quality improvement processes. And it requires boots on the ground, it's a little bit of effort, but not a lot. Like I just literally walk through the clinic as a patient once. And sometimes I go with a patient and they walk me through it, who do it. And it's very obvious right away where the problems are. But in any case, in order to make this as routine as possible, the first is that it's automatically assigned. So I heard that like Cerner at one of your institutions is electronic and others paper. So, you have to figure out what's going to work for your system. But Cerner, because it's electronic, there's probably a way, I almost guarantee you there's a way that you can look at visit diagnoses and say, okay, prostate cancer, bladder cancer. And that's the heavy lift, right? It's like identifying the diagnoses. But that's what we did. We just said, okay, any visit diagnosis that has bladder cancer or prostate cancer, there is a patient-reported outcome measure that is automatically assigned to that patient. And they can complete it at home in their MyChart. That's how we have like the record kind of goes in on their smartphone or their computer. Or if they don't do it, when they come in the check-in process, that the administrator who does the check-in, they do it like a vital sign. They're like, oh, it just pops up. It says, oh, you need this. Here's an iPad. Go ahead and fill that out. And it's automatic. As soon as they click submit, it is in the chart with the vital signs. So you can see the temperature, the blood pressure, the heart rate, the PROs, all done in a way that makes sense to the patient and to the clinician. So we shopped around different, we wanted to make it really simple, like lines, just like a drawing, really. And it automatically calculates from the last one if it's going up or down. And because the clinicians were like, I never remember, it's like good up, bad down. There's an arrow, and it literally says good up. So we just did that, but we asked the question, we made it very usable. And what the clinicians wanted, including myself, is we have templated notes. So probably in Cerner, you probably have that. And you just pull up the templated note. It automatically has it in. All you do is refresh, and their score is already imported into your note. So when you're talking to the patient, you have the note up. You can quickly see, and it turns red if they have a decline in some kind of symptom. And there's research behind it. So you can say, this is the decline that's clinically significant or meaningful, and you define it. And in the computer, it's like a program. You just create that program and boom, right away. And so it saves me a lot of time because I can get right at the heart of the issue. And then I can always say, is there anything else? But we do that all the time. And how many times that doesn't always work. Sometimes it works like when your hand's on the door, right? Like we're time, but you're trying to avoid that, right? And that hopefully gets that out of there. So in any case, that's that. So I'm keeping an eye on time. Examples of patient engagement and research. I want to have a little time at the end for, discussion and questions and whatnot. So there's lots of examples of this. I really like this review because this is specifically about urologic oncology. Svetlana Avalova did this. Daniel Lee with Dan Barocas. And what they were looking at is how much patient engagement is being done in the design of and the execution of urologic oncology research. And the answer is not a lot. So there's a lot of room for improvement. And if this is an area that you're like, this is really interesting to me, join. I always say, we didn't really get into this, but I was a music major in college, and in middle school to high school, my mom was a music director. And anyway, long story short, she needed a euphonium player. Does anyone know what a euphonium is? Okay, it's like a tuba. All right, no one would ever. Good. I heard you knew it. You don't have to be embarrassed. Okay, you're in good company here. Very cool people play the euphonium. But in any case, I played it, and I always joke around, you can be the best at something if no one else is doing it, right? That's the truth of it. And guess what? I got a full ride to college with my euphonium scholarship. Yes, I did. And here I am standing. And do I own a euphonium? No. Have I played it in 10 years? No. But my point in saying that is when you're thinking about your career, look at the gaps. And you need to also have a passion for it. You need both. But when you mix those two things, really great things happen. That's what I did. There was no one doing this. I was really passionate about. I still am. I really love it. And it keeps me active and engaged in my own work. So anyway, there's lots of room for this, and certainly in all other areas of urology as well. Have you heard of CSER? CSER, for those in prostate cancer, this is a very large comparative effectiveness study funded by PCORI comparing radiation and prostatectomy, and lots of patients, but lots of things have occurred from this. And, you know, I swear like every 3 months there's a publication on something that we didn't know about. You know, the quality of surgical care. Sometimes it's sexual function. That was, I think, one of the more recent ones. But it's important because these large pragmatic trials is where patient engagement can be really critical. And that's how they conducted this prostate cancer trial. And if you take it one step back, it's really understanding what questions you should be asking to begin with. And so this is Yao Yame from University of Washington. And so we worked together. He did the work to basically create a infrastructure to understand what are the poignant questions faced by patients with prostate cancer. And so, you know, there's lots of steps in the engagement piece, which is like, you know, you want to build the partnership with patient advocates. You want to identify those key research questions. You want to be open-ended with like developing which questions matter, because not all patients, the way that we ask a research question is not going to be the way that they ask it. It's a different language. So you need to have patient advocates helping you with this. But then you ask them, and then you end up ranking them. But you can see for like localized prostate cancer, things that came up or decision aids, like the use of them, pre-treatment counseling, surveillance test treatment of high-risk prostate cancer for recurrent prostate cancer, early use of EADT, PET tracers, decision aids, advanced prostate cancer treatment sequencing, treatment side effects, on and on. So this is really important, though, because we have limited funds to conduct research. And so we really need to know where we want, you know, where the patient questions are, where our own questions are for providers. It's the whole piece that you need to address. So now I'm going to go into, I told you, I promised you I was going to kind of go through my own story of how I got involved. And I got involved in that way, is thinking through research prioritization, and just, you know, very briefly walk you through the process that I went through, and then we'll go through some strategies. Anytime you do patient engagement, I think it's really important to figure out if there's a patient advocacy organization that you can partner with. And for me, that's the Bladder Cancer Advocacy Network. I know Pierre is like very much involved with them, and they're wonderful. And I remember my very, very first meeting at Beacon. It was almost, I guess it was like 10 plus years ago. John Gore he had a working group, and it was very unique because in this working group, they were addressing like patient-centered outcomes research and things of that nature. And when they had that, everyone at the table was a little different. Like there was actually a social worker there. I remember there was a nurse there. There's some urologists. There was a radiation oncologist who attended, patients, a caregiver. You know, there's a lot of different people. And at that very same time, again, it's like all about paying attention. PCORI had put out this brand new funding mechanism for engagement. And they were like, you know, what this is meant to do is to create, you know, the money is meant to create an engagement infrastructure where you can call upon patient advocates and create a structure where patient advocates can be helpful in the research process. And I was like, ding, ding, ding. Like I already have all the raw materials here. What if we did this, right? So I already knew there was a lot of evidence for engagement in study development and study conduct, study dissemination. And I educated myself before I like really went into this, but I knew that I could do any of these things. But I figured, why not start at the beginning, which is topic selection, prioritization. And that's sort of where I started. I realized that doing all of this would have all these benefits, you know, and we already kind of went through that, how the patients access information, all of that. But I was like, you know, if I start there, for me, it was a good learning experience. And then also it would allow us to know whatever we were going to study had some meaning. And so we created what we now term the Beacon Patient Survey Network, and it has probably about 1,500 patients. I actually also partner with Bladder Cancer Canada as well. And so there's a lot of Canadian patients in the PSN. and some other international patients as well. But the idea was to get a better sense of what research questions were important. And I'm skipping a little ahead. So I did essentially what Yao did for prostate cancer is what we did. We had done this earlier in bladder cancer. And then once we had those research questions, we disseminated them because, like, what do you do with them then? Well, you got to get it out there. And how do you do that? So one way I did that was I contacted all the funding agencies. So the NIH, PCORI, our Agency for Healthcare Research and Quality. And I just told them about it. And it was interesting because they were like, we have never seen this before, but we'd like to incorporate this into our review process in some way. And I said, okay, that's great. And had some meetings with program officers, and that was that. I published it, because you can, if you want to do something, we want to put it in a journal. So if anyone wants to reference it, especially for a grant, they could say, hey, this is really important. When you write a grant, it's really important to have a good significance section, right? This is perfect for that because you say, not only is this significant, and I'm telling you that as a researcher, but the patients also feel this is significant. And lo and behold, PCORI, which I don't know if I mentioned, it funds lots of things. I mean, it funds pediatrics and dental things, and I mean, not just cancer, certainly. Well, they put out about 15 to 18 priority areas each year, and bladder cancer has never been on the list ever until the year after I gave them this list. And I can't think that's coincidental, right? And so what was their question? It was about patients with high-risk non-muscle invasive bladder cancer. After BCG stops working, do you proceed with cystectomy or some kind of medical management, intravesical or whatnot? And so from there, we were really pleased to see it. And then we realized maybe we should answer that question. But we had a little bit more work to do. And so we did a few more engagement awards because I knew that, yes, we had created the research priorities, but now, how do I get a patient advocate to join my team? How does that work? I didn't know how it worked. So we created a couple training mechanisms. The first is called PEER. And this was they call them contracts, not grants in PCORI, but there's a contract, patient empowerment through engagement research training. And essentially this was the model, all right? You have, there we go. We had the PSN already existing. The PEER program was to prepare patient advocates in engaging. And so we basically had modules created to engage them into the process, taught them about bladder cancer. It was funny because we're like, well, is it really knowledge? Well, we tested that, but really it is actually just whether they could do it and also whether they were confident at the end of the process, because that's key. I want to be really clear about this. We're not doing this to get a patient to be us. We already are us. We did the research training. We don't need another one of us. They're already an expert in what they need to be, which is the experience of having the disease. That is what they're there for. And so, but they have to believe that they need to have the confidence. And so that's why this was created. We created a mentorship program. We actually fund it through industry because industry now is getting more and more patient advocates, and they get it through our system. And there is a fee, it's like a finder's fee, that is given both to the patients and also to Beacon to continue this process. So, you have to be creative on how to sustain this because I can't get a grant every year to keep this going. Eventually it's got to fly, and now it's flying. And so we created a mentorship program, and then we were like, well, let's do an experiment looking at comparative effectiveness research based on that. And what better experiment, right, to use some kind of patient-informed research question that was already a priority from PCORI, use patient-informed study outcomes, and then create a patient-informed research design. So essentially, it's the what of what we're doing and the how we're going to do it. So going back to this PCORI thing, this announcement said that they wanted to look at mortality and progression to invasive disease. They wanted to look at side effects and quality of life. But interestingly, they said preferably an RCT. How many people interact with patients with bladder cancer in here? Yeah. So yeah, okay. So good amount. This is a very preference heavy decision. Could you imagine randomizing saying, I'm going to let this envelope decide whether we take your bladder out? No way. It just. Right, exactly. And that's exactly what we ended up, we didn't do a self-randomization in that way, but we ended up deciding, and I'll show you how we did it, but we ended up deciding to do a prospective cohort study, very large enough to address some of the confounders. But we already know that randomizing that is not feasible. That's actually been shown already in the UK. It's not it's not an easy process, and that's in a place where there's less preference than there is, at least in the United States. But anyway, we knew that the research question was good because our number one and number two question from our patients in the survey network was about this exact topic. We actually went back to the 1,300 patients and we asked them, rank what's important to you. What are the that are most important? And so you could see there are some things that Pecori had mentioned, quality of life and survival, but there were other things that came up that we hadn't even considered. Caregiver burden, because a lot of these patients are older and they actually care a lot about how it's affecting their family, whether they can retain their bladder, and then the financial burden of all of it, which is a big cost, especially if you retain your bladder. There's a lot of costs, at least in the US, for surveillance and et cetera. And then we asked them, simple. I mean, how many times do we, when we do a clinical trial, do we actually ask patients whether that beforehand, whether it's going to happen or not? I mean, look at this. This would never work. 90% of people who are actually quite engaged said, no way, I'm not going to randomize to this, right? I asked the flip question, which I'm not showing, which would you do it if you got to select the treatment? And they said, yes, no problem. It was the flip. It was 90%. So we knew our design. But when you're putting in a grant, you kind of have to show them. I knew I was going to have an uphill battle. They wanted an RCT. I had to prove to them why an RCT was not going to be useful in this particular setting. And so you need to do, that's where patient advocates can really be very helpful. We also took little quotes. This is like something I still do to this day in grants, is take a patient quote and just insert it, because it really does bring it back to the purpose, especially if you're doing something very clinically relevant to the purpose of the project. So you can see patients are asking the risks of having that bladder removed. They need to be better quantified so you can make an informed decision. I want the choice based on the experience of others. They wanted to know how patients arrived at their decisions. This decision's a gamble at best. Understanding the outcomes and how the patients arrived at their decisions. That's what they needed. And so it's good to know that, because that's how we ended up designing it. And so this is the final design, and I don't have slides on this, but we're at 60% enrolled at this point, and so we have a couple more years to finish this. But this is a relatively rare facet of bladder cancer in the realm of bladder cancer, at least. So we have 32 sites just to get the numbers, and it's a challenge because it's such a heterogeneous type of population in terms of what they've had before. So this is a pragmatic trial, and we include unresponsive, relapsing. We have, of course, definitions, and then the patients choose either they have their bladder removed or they choose some kind of medical management, whether it's pembrolizumab or intravesical therapy. And the primary outcome was decided by the patients. It's the health-related quality of life. But then we also have secondary outcomes like their progression to invasive cancer, bladder cancer survival, sexual function. You'll see financial toxicity made the list because they brought that up. Decision regret made the list because they brought that up. Because a lot of these patients have lived through it and they're like, that would have changed my mind. And then we did an AIM-2 where we are looking at the decision-making process through time trade-off and all of that. So because of the time, I'm going to kind of roll a little bit through this, and I'm happy to talk more about the study, but I wanted to show you how I went. That was like 8 years of work, but that's how, if you kind of continue following a passion, it can lead to really big, that's a $9 million study. It can lead to really big things. Engagement structure is a little different. We have a statistician, so data coordinating center. We have a clinical coordinating center. Those are your site, PIs. But we have, interestingly, a stakeholder coordinating center. So we actually have a patient advisory board that I meet with every single month. We go through various different things in the trial, any issues we're having in recruitment, and so forth. And lots of changes have come from them. We have a recruitment video, so helpful. And they recorded it. Like, it was the patients doing it. And that's one of the common comments we get back from patients who enroll, is that how helpful that video was, because it came from an actual patient who has the disease. They didn't like the word trial because that, in a patient's mind, even though there's differing definitions for trial, they equate that with lack of choice. So we remove that. That's really important because the study name can make or break something, right? The way they're thinking about it. We timed the survey, figured out how we were going to ask the questions in what order. We actually added some questions. One was about a second opinion, which is really important to them. And I think it was a great question. I was like, that's a great idea. I hadn't even thought of that. And then clarifying questions. So we asked history of radiation. And you know what they thought? That was, all of them thought this. History of CT scans. So how interesting is that, right? That you're asking a question to them about that, and you might have gotten completely the wrong answer because you didn't ask like what they meant. Yeah. I'm gonna go ahead and end. Yeah, so I will just say there's lots of big tools that exist. There's a GRIP reporting checklist. There's if you want to do clinical trials, there's a checklist on how you do that. Very easy. It's a protocol that literally you can lift and just fill in the blanks. I already talked about partnering with advocacy organizations. There's so many out there. Look for one and partner with them. And then of the clinical setting, all you have to do is ask some patients. And that's what I do. I actually have a list of patients who are, I'm like, are you interested in doing something in the future? And they usually say yes. And I just keep them on a list. And I just make sure that I embrace diversity. We just touched upon that. And the last thing I'll say is the AUA actually accepted as a course this year. So if you are really interested, you can join the course. And so GOD is leading it, and then some of my partners. And so I always say, too bad patient-centered research, not rocket science, because if it was, we'd be really good at it. So special thank you to my team, John Gore, especially because he's my research partner. I always say it's fun to do research, really fun to do it with your best friend. And then my teammates at UNC and Beacon and all my patient advocates, and this is my family. So thank you again for the invitation.